Hello, welcome back. I'm Dr. Mark, and today we are going to discuss one of the most delicate moments talking about physiology a human being can go through, and this is, of course, pregnancy. And we are going to look at specifically how pregnancy and all of the hormonal changes these patients go through can lead to the appearance of de novo diabetes, or a patient that already had diabetes gets really worse during a pregnancy. So we are going to talk about this relationship between diabetes and pregnancy. Let's take a look at the information. So as we've seen in previous videos, diabetes is an imbalance between insulin and those carbohydrate metabolism disturbance. So the lack of insulin or the presence of counter-regulatory hormones to insulin lead us to a dysfunction of this important hormone and thus to glucose levels in our blood. This is the carbohydrate metabolism disturbance. It shows up or worsens during pregnancy. So patients that previously had diabetes and become pregnant, or patients that were healthy, they are both at risk. Of course, at different levels of risk, but they are both at risk, and they both should know about the risk of diabetes during pregnancy. Its progression is associated with the increase of hormones during pregnancy, especially when we have diabetes mellitus type 2 or gestational diabetes. Those are two very important types associated with hormone changes, and it can lead to severe complications during pregnancy for both the mother and the baby, including the death of either one of those or of both of them. So it's really important that we have in mind when a patient becomes pregnant that this is something we have to check, we have to monitor, and we have to protect our patients from these diseases. So we were talking about in a previous video, in the video about what is diabetes, that I will leave a link up here so you can check it out. But basically diabetes is a problem of balance. We have the hormones that are like insulin, like insulin and insulin's friends, where we can find, of course, incretins, a hormone that we will discuss further down the line. But the main thing is insulin. When we eat and energy we have over the amount we need, then insulin is released, and this is the message for the rest of our body to store that excess glucose so we can use it when we're hungry, when we haven't eaten. We can find here our first type of diabetes. When we destroy the cells that produce insulin, we have type 1 diabetes mellitus. Now, when we, of course, are not eating, when we are fasting for a long period, then we need, it's not only that they are good, it's that we need them to survive, the counter-regulatory hormones. So all of the hormones that block insulin function, and that leads all of these stores of glucose to be released into the bloodstream. And we talked in the previous video about some of these hormones like epinephrine, cortisol, resistin, and cytokines. Patients that undergo pregnancy, pregnant patients, have their own ICRH. So they have all of these, of course, but they also develop, as a natural part of their pregnancy, things like placental lactogen, progesterone, and estrogens. These three, among with the other natural ICRH hormones, can lead to an imbalance in, of course, this delicate system, to this insulin sensitivity, and lead to insulin resistance. So a patient may develop gestational diabetes when the sum of all of these hormones, the ones the patient already had from normal life, and the hormones associated with pregnancy, when we take out these pregnancy hormones, the patient may reverse to a state without diabetes, because these were the main culprits of course, this diabetes in that particular patient. Or we can have a patient that already had some insulin resistance. Of course, the pregnancy hormones lead to diabetes, and after we finish that pregnancy, this balance does not return to normal, and we have a patient that continues with diabetes. Finally, we may have a patient that before pregnancy had already diabetes mellitus type 2, so these hormones were too high and these hormones couldn't compensate, and thus that diabetes gets a lot worse because the presence of these extra ICRH hormones. Once again, we have three patients. This is what we were explaining. The patient that just lost, because of autoimmune diseases, the cells that should produce insulin, that is type 1 diabetes mellitus, These patients, of course, also get pregnant, and we have to be careful when they get pregnant because they will have like the normal complications of pregnancy, and we will have to be very strict with the insulin they are applying. These patients always need insulin because they don't produce their own insulin. But previous doses might not be sufficient because we have now more of the counter-regulatory hormones, the ICRH. We have the second example of a patient with type 2 diabetes mellitus that becomes also pregnant. This patient, we also need to take into account one, the treatment they had for diabetes, because not all treatments can be given during pregnancy. We have to be very strict with the nutrition of these patients because, once again, when they have more ICRH during pregnancy, this leads to a more complicated diabetes mellitus type 2, and this may accelerate all of the complications this patient may develop. And finally, a patient that was quote-unquote normal, so quote-unquote didn't have diabetes. These patients usually already have some insulin resistance. For example, a patient with PCOS, with obesity or something else, becomes pregnant. Once again, that patient did not have the diagnosis of diabetes mellitus type 2, but during the pregnancy, they develop gestational diabetes. After the pregnancy, this patient with gestational diabetes might go back to not having diabetes, but it is also very frequent that these patients go to a state of diabetes mellitus type 2 if they are not very careful, once again, with all of the factors that lead to insulin resistance. And these are the three scenarios we can find and can lead the patient to this carbohydrate imbalance and thus the damage of their cells. The next problem we have with diabetes mellitus type 2 and of course gestational diabetes is that they are asymptomatic. So the patient doesn't feel absolutely anything during the pregnancy. They might think it's a completely normal pregnancy. They are not thirsty, they are not tired, they don't have a headache. They have like the normal things associated with pregnancy, nausea, fatigue, all those things. And thus, they don't detect that high insulin and glucose levels, and the patient has the complications. They might even lose the pregnancy and don't even know why. So from this moment on, I am going to focus a little bit more on gestational diabetes. Who can get gestational diabetes? A patient with, as we were mentioning, some insulin resistance before pregnancy or in the first stages of pregnancy. This is usually a patient with obesity or that is overweight. We can also find it, very importantly, on other causes of insulin resistance. I was just mentioning polycystic ovary syndrome, patients with Cushing, with some other disease that causes insulin resistance. A patient with history of gestational diabetes. So in my pregnancy 3 years ago, I had the diagnosis of gestational diabetes. It's very likely I will also have it on this new pregnancy. And even if I didn't have the diagnosis, if I had a large for gestational age baby or a macrosomia baby, this is what I was describing, a macrosomia baby. This is a newborn, so it has just a few hours since it was born, but it weighs over 4 kilos. That is quite a lot for a baby. Of course, we can see it's a much larger size, and it also has some other differences that I am not going to get in here, but they look different. Those babies, if I had a baby over 4 kilos, that means I most likely had insulin resistance, and that's why the baby was such a large baby. The next pregnancy, it's almost certain that I will also have a very large baby if I don't take care of myself, and of course that I will develop gestational diabetes with all the complications that this may ensue that we will talk in a little more. If I had a history of diabetes within my family, of course, we are mainly here focusing on gestational diabetes and diabetes mellitus type 2. These two risk factors are the ones associated with gestational diabetes during pregnancy. Once again, diabetes mellitus type 1 doesn't count as a risk factor. And lack of preconception counseling. One of the most important things that we should do when we are planning a pregnancy, when we can get pregnant, is ensure we are very healthy, we have a proper diet. If we have insulin resistance, to treat it before we start our pregnancy. That is absolutely essential for a healthy pregnancy, and of course avoiding these types of diabetes during pregnancy. Now, how can we diagnose it? Since we are saying that the patient will not feel anything, we can't rely on the patient's feelings and the patient's symptoms and signs to tell us that diabetes is appearing. So the guideline is to test all patients. All patients should get a test when the counter-regulatory hormones present during pregnancy are at their peak. So most patients, we are going to do like a test, like a challenge. We are going to give oral glucose in high doses, and we are going to measure that glucose in their bloodstream in a curve, so a couple of hours after they drank that glucose. And this test should be done in the weeks 24 to 28. This is for low-risk patients. So any patient that is pregnant should have a glucose tolerance curve during weeks 24 to 28. If we have a very high-risk patient, so a patient, for example, that had a macrosomia baby in the last pregnancy, gestational diabetes on the last pregnancy, a lot of family members with gestational diabetes or diabetes mellitus type 2, then we may do this test, the tolerance curve test, in week 14. So much or a lot sooner than the peak of counter-regulatory hormones, that is 24 to 28, and we do it in the 14th week of pregnancy. This gives us a lot more time to say, okay, we now know this patient has gestational diabetes or poorly controlled diabetes mellitus type 2 during pregnancy. We have to give treatment sooner to avoid all of the complications. I am not going to get into the crux of how is this test done. Let's just say that the patient will have to drink a lot of a very sugary drink, so it's a thing basically made of sugar, and then we are going to serially take blood samples through different hours, and we are going to present that curve of how glucose behaved on the patient's bloodstream. So what are the objectives of treatment? Of course, we should basically have a normal glucose level for the circumstances of the patient. This means that if the patient has been fasting, we should be under 92 milligrams per deciliter. Glucose tolerance curve, we should be after an hour under 180 milligrams per deciliter, and after 2 hours of drinking that really sugary drink, under 153. And glycosylated hemoglobin, of course, this is the main measurement we use that indicates the last 3 months of a patient's glucose control. We should be under 6.5%. This all leads to a very healthy pregnancy and a patient with a very low risk of complications. If we find some of these things altered, we can make the diagnosis of gestational diabetes, and we should start treatment right away. So the main thing, the main element of treatment, as is for most of cases of diabetes, at least diabetes mellitus type 2, and this now gestational diabetes, is diet and exercise. In these patients, we should really monitor how the patient is gaining weight. Of course, every pregnant patient should gain weight because they are like creating a new body inside of their own body. But we have to be very strict with how much they can gain weight. They should, of course, have a very healthy diet. This healthy diet entails a high consumption of fruits, of vegetables, of fiber, of water, and of course, eliminating from their diet all of the ultra-processed foods, like cola, like all of the ultra-processed foods. They should also have a significant amount of exercise, of physical activity. All of this we've already spoken about in that other video, so I won't get into too much details here. And if we don't manage to, or if it's a very severe gestational diabetes, if the patient has altered levels of glucose and of course a high level of insulin resistance, we should of course use insulin and metformin to manage these patients. Insulin will be the much more standard treatment for gestational diabetes, but metformin can also be used. Now, what are our main objectives? So, remembering once again, a patient that has insulin resistance, so diabetes mellitus type 2 or gestational diabetes, they have in their bloodstream a lot of insulin and a lot of glucose. Insulin cannot cross the placenta, so the baby will not be affected by just the high insulin levels the mother has. The thing is, high glucose levels in the mom, they do cross the placenta, they do reach the baby, and the baby has its own pancreas, and its own pancreas has its own insulin. So those very high levels of glucose lead to very high levels of baby insulin, and insulin is a growth factor. This leads, of course, the baby to have the risk of malformations, so parts of their body grow more than the rest of their body, especially, for example, cardiac malformations and a heart that doesn't work the way it should, even leading to the loss of the pregnancy. And finally, this may also lead to a very large baby, as we were talking about previously. So a macrosomia patient, a macrosomia baby, is a baby that was exposed during his or her gestation to very large insulin levels. Once again, insulin produced by the baby because of the high glucose levels from the mom. If we give insulin to the mom, glucose levels decrease. Insulin, as we said, does not cross the placenta, and thus the baby is protected and the baby can have a normal development. So how can we prevent these complications and this toxic relationship between diabetes and pregnancy? Number one, we need preconception counseling. Every patient that is going to get pregnant, that can get pregnant, should be very healthy, because being very healthy is, of course, the best gift, the best health gift we can give a baby. The fact that the baby develops inside a healthy body, the mom's healthy body, is going to have a deep impact on the rest of that baby's life. So we need moms to have the best health they can. Number two, we need an early diagnosis. If a patient has insulin resistance, we have to find it as soon as possible and manage it. Lowering glucose levels will be our top priority to ensure and diminish complications for the mother and for the baby. Number three, we need to manage weight increase. As I was saying, we need patients to increase no more than 13 kilograms. That is a patient that before the pregnancy had a normal weight. And a patient with obesity, we need to be more strict, and these patients with previous obesity can only increase 9 kilograms. For my American friends, 13 kilograms are 28 pounds and 9 kilograms are 19 pounds. So we can't let a patient increase more, because if they increase more, the risk of gestational diabetes is much larger. We need also an adequate diet and constant physical activity even during pregnancy. During all of the stages of pregnancy, a patient can exercise, of course, with, especially in the third trimester, special exercises that are less demanding and that accommodate this new mass the patient has in its pelvis. So what are the complications we're trying to avoid? For the mother, we first have preeclampsia or eclampsia. This is, of course, preeclampsia is like the step before eclampsia. This is a very severe complication associated with hypertension, with convulsions, and the patient may die from eclampsia. We can have infections and sepsis, especially during a C-section or during like a delivery. This is because, of course, the alterations to the immune system and the process of delivering a baby associated with high levels of glucose. And, of course, the patient staying with diabetes, especially diabetes the mellitus type 2. And, of course, having all of the complications we previously mentioned in the video of what is diabetes. For the baby, we also have very severe complications that may lead to its death. So we may have hyperbilirubinemia. Hyperbilirubinemia is very severe because it's not just a yellow baby. We might have with very high levels of bilirubin. They reach the brain and they cause very severe complications, destroying parts of the brain in a disease called kernicterus. We have large for gestational age and macrosomia. That's a very large baby, and of course a very large baby may have its own complications, hypoglycemia, other things, but it also may be too large to get out, causing in the mom tearing, causing bleeding, and of course causing other complications. We may have malformations, mainly of the heart, but some other organs may also have malformations. Neonatal hypoglycemia, because the baby had like a constant drip of very high levels of glucose from the mom. When they are disconnected, the baby does not have the reserves of glucose he or she needs, but they do have very large levels of insulin because of all the glucose they were having, and so they develop neonatal hypoglycemia. If not treated, this may kill the baby, and the way they can treat it is through a glucose drip that once again may lead to more metabolic disorders. They present respiratory distress syndrome, so lungs that don't function properly, and a baby that has problems breathing and may need to have some type of special equipment to allow those lungs to work, and of course a miscarriage. So losing the pregnancy in some of the earlier phases is also a complication of a diabetes, gestational diabetes, or an uncontrolled diabetes or poorly controlled diabetes associated with pregnancy. Of course, this is all of the information I wanted to share with you today. I am going to, as always, leave these references so you can check them out, learn more about this important topic, and please be very careful and take care of yourselves before a pregnancy and during a pregnancy. Well, that's everything for today's video. Thank you much for watching it, sharing it, liking it, and all of the other things you can do with this information. And as always, help us change the world, share the information.